Good day everyone. Today I'll be discussing diffuse connective tissue diseases which are scleroderma, polymyositis, and polymyalgia rheumatica.
Rheumatic disorders, the scleroderma, polymyositis, and polymyalgia rheumatica. This will be the content for this video: the description, etiology or the causative factors, pathogenesis or pathophysiology, signs and symptoms, diagnostic and laboratory procedures, medical management, nursing diagnosis, and the prognosis for each disorders to be discussed. First up, scleroderma. What is scleroderma? It is a compilation of autoimmune diseases that affects the connective tissue of the skin, blood vessel walls, and internal organs. It is similar to other autoimmune diseases. Women are affected 3 to 5 times more than men, and the onset typically occurs at the ages of 30 to 50 years. There are two types of scleroderma: the localized scleroderma, which affects only the cutaneous system, and the systemic scleroderma, which affects multiple organ systems. The etiology or the causes of scleroderma, the genetics, environmental factors, and the immune system problems. For the pathogenesis or pathophysiology of the scleroderma, it is poorly understood. It commonly begins with skin involvement. The mononuclear cells cluster on the skin and it stimulates lymphokines to stimulate pro-collagen that causes the endothelial dysfunction. Insoluble collagen is then formed and accumulates in the tissues, and that would result to vascular damage and chronic inflammation. Initially, the inflammatory response causes edema with the resulting taut, smooth, and shiny skin appearance. The skin then undergoes fibrotic changes, leading to loss of elasticity and diminished movements. Eventually, the tissue degenerates and becomes non-functional. That would then result to ulcers and amputation. This chain of events from inflammation to degeneration also occurs in blood vessels, major organs, and body systems. Signs and symptoms. For the cardiovascular system, patients may experience Raynaud's phenomenon and swelling in the hands, pitting ulcers that are healed, and mucosal telangiectasis, palpitations, fainting due to conduction abnormalities, hypertension, and congestive heart failure. For the digestive system, gastroesophageal reflux disease, bloating, indigestion, loss of appetite, Zika syndrome, diarrhea, loosening of teeth, and hoarseness due to acid reflux. Pulmonary system, shortness of breath, chest pain due to pulmonary artery hypertension, and dry and persistent cough. For musculoskeletal system, joint and muscle aches, loss of joint range of motion, carpal tunnel syndrome, and muscle weakness. For the genitourinary system, erectile dysfunction, dyspareunia, kidney problems, and kidney failure. Lastly, for other systems, facial pain, hand paresthesias, headache, stroke, fatigue, calcinosis, and weight loss. For medical management, all patients require counseling. Support measures including strategies to decrease pain and limit disability. A moderate exercise program is also encouraged to prevent joint contractures. They are also advised to avoid extreme temperatures and to use lotion to minimize skin dryness. For the pharmacologic therapy, calcium channel blockers and other antihypertensive agents are given. Anti-inflammatory medications and proton pump inhibitors are also given. Aspirin are used to help reduce cardiovascular risk factors. Vasoactive medications are given, and also immunosuppressive agents and antifibrotic agents are given. Ultraviolet A irradiation is sometimes used to decrease the synthesis of collagen in dermal fibrosis and improve skin symptoms. For the nursing management, the nurse provides meticulous skincare, helps in preventing the effects of Raynaud's phenomenon like exercising, elevating the head of bed, and referral to the occupational therapy. The most common nursing diagnoses are impaired skin integrity, self-care deficit, imbalanced nutrition less than body requirements, and disturbed body image. Lastly, the prognosis. The 5-year survival rate for systemic scleroderma is about 85%, whereas the 10-year survival rate is just under 70%. This varies according to the subtype. While localized scleroderma rarely results in death, the systemic form can. And the diffuse systemic form carries a worse prognosis than the limited form. The major scleroderma-related causes of death are pulmonary hypertension, pulmonary fibrosis, and scleroderma renal crisis. People with scleroderma are also at a heightened risk for contracting cancers and perhaps cardiovascular disease. Next is the polymyositis. Polymyositis is a group of diseases that are termed idiopathic inflammatory response. The muscles affected by polymyositis are the skeletal muscles on both sides of the body. It is most common in women than men, and usually seen between ages 40 and 50 years. Etiology. The exact cause of polymyositis is unknown. The risk factors are lupus, rheumatoid arthritis, scleroderma, Sjogren's syndrome, viral infections like HIV and AIDS, and diseases that affect the ability to breathe. Next is the pathogenesis of the polymyositis. The etiological factors causes the autoantibodies to bind with the DNA or RNA in muscles, provoking a systemic inflammatory response. Then there is an increase in chemokine and cytokine release in the endothelial vasculature of muscles that then results in perivascular inflammation and capillary necrosis. Capillary necrosis occurs in the skin and dorsum of the hands, forming hyperkeratotic, flat, red papules and also occurs in the upper and lower eyelids, causing the red-purple discoloration with or without the swelling. Then the perivascular inflammation and capillary necrosis results in the fascicular hypoperfusion and muscle ischemia because of the lack of blood supply to the myofibers. It then causes muscle tissue damage. The inflammatory infiltrates destroy cellular components of the muscle. Next are the signs and symptoms. The patient would experience proximal muscle weakness, difficulty rising from a chair, climbing steps, or holding up the head, myalgia, muscle tenderness, weight loss, fatigue, joint pain, and Raynaud's phenomenon. And the different diagnostic and laboratory procedures used or are needed for diagnosing polymyositis. Physical examination and history taking, serum studies, muscle biopsy, electromyogram, and magnetic resonance imaging. The medical management for polymyositis: corticosteroids, immunosuppressive agents, physical therapy like range of motion exercises and gradual strengthening exercises, speech therapy, and intravenous immunoglobulin. Nursing management: the use of assistive devices may be recommended and the referral to occupational or physical therapy. The different nursing diagnoses: impaired physical mobility, self-care deficit, fatigue, and the deficient knowledge of self-management techniques. Lastly, the prognosis. The long-term outlook for people affected by polymyositis varies. Most affected people respond well to treatment and regain muscle strength, although a certain degree of muscle weakness may persist in some cases. In most cases, polymyositis is not life-threatening, and many people recover partially or completely from the disease. People who recover from polymyositis after treatment may be at risk of a recurrence of symptoms. The last disease to be discussed is polymyalgia rheumatica. Polymyalgia rheumatica, it involves stiffness of the muscles and pain in the neck, shoulders, and pelvic girdle. The pain can be very sudden or it can occur gradually over a period of time. It primarily affects individuals older than 50 years of age. Etiology: the etiology or exact cause of polymyalgia rheumatica is unknown, but it can be genetics, environmental exposure. Age, sex, and race are risk factors of polymyalgia rheumatica. Next is the pathogenesis. The underlying mechanism of action is unknown. However, it is clear that the immune system is abnormally activated in the disease processes with increase in circulating monocytes that produces IL-1 and IL-6. That then activates the inflammatory cytokine production and then the Th1 response in vessel wall. Then these circulating monocytes make the endothelial linings of the blood vessels more vulnerable to vasculitis. Then there is also a no autoantibody component. Signs and symptoms. The signs and symptoms are severe proximal muscle discomfort, mild joint swelling, severe aching in the neck, shoulder, and pelvic girdle or muscles, stiffness, and some systemic features like low-grade fever, weight loss, malaise, anorexia, and depression. The different diagnostic and laboratory procedures to be used are physical examination due to weight taking, CRP or C-reactive protein level and platelet count, markedly high ESR or erythrocyte sedimentation rate, ultrasound, and magnetic resonance imaging. The medical management for polymyalgia rheumatica: corticosteroid therapy, NSAIDs, calcium and vitamin D, methotrexate, and physical therapy. Nursing management: preventing and the monitoring of adverse effects of medications, and the adjusting to those side effects that cannot be prevented. Nursing diagnosis: pain, and the deficient knowledge of medications. Lastly, the prognosis. With careful monitoring and treatment, most people with polymyalgia rheumatica or temporal arteritis have a normal lifespan. Most of the time, these diseases can be successfully controlled with steroids and other drugs. And that is all for this video. Thank you for watching.